Hello everyone, let's discuss about acute pancreatitis. Acute pancreatitis is the inflammation of the pancreas. Pancreas is the organ which is located in our abdomen. It is the mixed gland which has exocrine and endocrine component. The hormones which helps in the digestion is trypsinogen which comes from the exocrine portions of the pancreas. There is the exocrine glands in the pancreas which secretes the trypsinogen. The trypsinogens is converted into the trypsins by intraacinar activations. This trypsins is highly toxic, so it might cause intense inflammations resulting in acute pancreatitis. Let's see the about acute pancreatitis. Before that, let's compare acute and chronic. In acute pancreatitis, there is inflammations, biochemical derangements, but no permanent loss of the tissue. But in case of chronic, there is recurrent pancreatitis resulting in fibrosis and permanent loss of tissue. Chronic pancreatitis is irreversible. Let's see the risk factor or causes of the acute pancreatitis. We have mechanical, metabolic, and others, or we can simply go through the point. The most common cause is gallstone. It mostly occurs in the women. The size of the stones will be less than 5 mm to cause obstructions. It occurs in almost 40 to 70% of the cases. The second important cause is alcohol. The mostly men are alcoholics, so it is commonly in men, but female might also have alcoholic pancreatitis. Its incidence is 25 to 35%. Generally, the binge alcohol might result in the acute pancreatitis. Binge alcohol means drinking of alcohol at a large amount in a single time. The next cause is hypertriglyceridemia. The normal is less than 200. If it is more than 1000, then there might be higher chance of occurring pancreatitis. Next is ERCP, endoscopic retrograde cholangiopancreatography, some drugs, trauma, genetic diseases like cystic fibrosis, pancreatic divisum, cellular pancreas, hypercalcemia, infection like mumps, Coxsackie virus, etc. Now let's see the clinical features. In clinical features, we can say 2 out of 3. That is, first is clinical features, which is abdominal pain, pain in the epigastric regions, severe pain, which radiates to the back. We can assess the pain score of the patients. Generally, the pain score is say 8, 9, or 10 in case of acute pancreatitis. The pain radiates to the back, and the patient feels there is less pain while leaning forward. This sign is called Muhammad prayer sign. And other is rigidity. There might be board-like rigidity of the abdomens. The patient might vomit. And next is biochemical evidence like serum lipase and amylase. Serum lipase is more specific and sensitive. There must be more than 3 times rise in this value, amylase and lipase. Or there is radiological evidence, USC and CT. CT is usually used for chronic pancreatitis to check the severity. CT to check the extent of the disease. Or if the patient goes to the DIC, or we can see some sign in the abdomen like Cullen sign, Great Honor sign, and Fox sign. Cullen sign is the discolorations of around the umbilicus due to hemiperitoneum. Great Honor at the iliac fossa, and Fox sign in the thigh. Let's see the classifications. We have Atlanta classifications. It is divided into mild, moderately severe, and severe. In mild, it resolves within 1 week. There is no organ failure, no local complications. In moderately severe, there is transient organ failure. It occurs for less than 48 hours. There is some local complication. In severe, there is ongoing organ failure or persistent organ failure which occurs for more than 48 hours, and there is local complications. Now let's see the clinical scoring. Clinical scoring, there are 3 scores: Ranson's, Apache, BISAP, out of which the Apache is useful because in Ranson and BISAP we have to compare the at admissions and after the 48 hours, but in Apache we should not compare. Let's see the Ranson score. Ranson score is divided into two types: with gallstone, pancreatitis after gallstone, or pancreatitis without gallstone. If there is gallstone and pancreatitis, we should check this point. At admissions, if the age is 55, WBC more than 60,000, blood glucose is more than 200, AST more than 250, LDH more than 250. And after 48 hours, we should check fluid sequestrations, base deficit, calcium less than 8, blood urea nitrogen more than 5, and fall in the hematocrit more than 10%. In BISAP score, we have the BISAP, blood urea nitrogen, impaired mental status, SIRS, age, and pleural effusion. If the score is more than 3 or more than 3, there is poor prognosis. Now let's see the complications. Complications is divided into local and systemic. Local is again divided into Atlanta, less than 4 weeks or more than 4 weeks. If there is less than 4 weeks, then it might cause APFC and APNC. APFC stands for acute pancreatic fluid collections, and APNC stands for acute pancreatic necrotic collections. And if this persists for more than 4 weeks, then APFC, acute pancreatic fluid collections, will result in pseudocyst, and acute pancreatic necrotic collection results in the WON or wall of necrosis. You can see here, this is the pseudocyst. This is the leakage of the trypsinogens from the pancreatic duct, resulting in the pseudocyst formation. Now let's see the systemic complications. They are hypovolemic shock, most commonly occurs in first 24 hours, arrhythmia due to hypocalcemia and electrolyte imbalance. It might result in sudden cardiac death, fall in the hematocrit, DIC. In respiratory, there might be atelectasis, ARDS, the most common cause of death, pleural effusion. Metabolic complications might include hypocalcemia, saponification of the fat, retinopathy. Let's see the treatment. We have treated. We should do aggressive resuscitations to this patient. We should give the fluid. Ringer's lactate is a choice for acute pancreatitis. We should give ventilation support. If oxygen is low, we should provide oxygen supplementations. We should provide antibiotic like meropenem can be given, ceftriaxone meropenem. And we should provide nutrition. We can keep the patient NPO for 6 to 12 hours. If there is no any nausea, vomiting, then we should initiate enteral nutritions. If we avoid enteral nutritions for more period, then starvations might result in the gut mucosal atrophy, which might cause translocation of the bacteria, resulting in spontaneous peritoneal bacterial peritonitis, SPP, spontaneous bacterial peritonitis. And we can give octreotide subcutaneously. Antioxidants and analgesics like NSAID, opioids, paracetamols can be given. But if there is refractory pain, then we can go for epidural analgesia. And for surgery, if there are some indications for surgery, but if there is gallstone, then we should remove the gallbladder. Thank you.